Welcome to The Backstory with Dr. Ricky Singh. This podcast is focused on bringing you the latest research-based information about dramatically improving health, well-being, and quality of life. And here's your host, Dr. Ricky Singh.
Welcome back to The Backstory. Hey everyone, I hope you had a good week. Last week we spoke with Dr. Chasen, who is the Director of Obstetric Ultrasound and a specialist in maternal fetal medicine here at Weill Cornell. And today we're going to shift slightly. We're still going to focus on women's health and reproductive issues, but focus on contraception, unintended pregnancies, the relationship between pregnancy planning, and maybe some maternal mental health, but really focus on things that you, the listeners, want to hear about. So my guest today is the Director of Complex Family Planning in the Department of Obstetrics and Gynecology here at Weill Cornell. She is very new to the institution, has been here almost 2 weeks. So please welcome Dr. Aileen Gariepy. Dr. Gariepy, welcome.
Thank you so much for having me. Pleasure to be here.
Oh, great. So tell me about you. We were talking before we started recording that you're new to the institution. Tell us about what you were doing before you came to Weill Cornell.
Yeah, I'm a subspecialist in complex family planning, which is a new subspecialty of obstetrics and gynecology. And so for the previous 11 years, I was at Yale School of Medicine to start a division of complex family planning and fellowship there.
I've heard of Yale. They do a nice job.
They absolutely advertise that.
So what is complex family planning? What does it actually mean? Who are the patients and what's the population you serve?
Great question. Complex family planning is centered on the more complicated aspects of abortion and contraception, because abortion and contraception and miscarriage care are certainly within the realm of generalists, obstetrician gynecologists, but not everyone who does a OBGYN residency has the skill set to take care of the sickest and most complicated patients. So, for example, during COVID, I took care of someone with a 23-week pregnancy a desired pregnancy, who was intubated on ECMO, about to start dialysis with end-stage organ failure due to COVID, who needed to become unpregnant because they could no longer ventilate or circulate her body because the growing pregnancy was pressing on the heart and the lungs. So to do a D&E, a dilation and evacuation, which is the most common way of performing a second trimester abortion, was more complicated than it would be for most people who got generalist training in abortion. It involved coordinating multiple subspecialties, involved coordinating with our colleagues in maternal fetal medicine who felt like it was not safe to try and induce her to go into labor and that she wouldn't survive that, and that it wasn't safe to do a hysterotomy or an incision like a C-section in the uterus because of how sick she was. So that is kind of the patients that we take care of are the people that others just can't.
Before we go into the topic that I want to talk about, which is contraception and unpregnant, I've never heard of unpregnant, so we're going to talk about that. For this patient you mentioned, not to mention consent. How do you even inform or get that from the power of attorney or family member to do this?
Yeah, this was all long. Her care was extended over a month and, deteriorating slowly over time. And so her sister was her power of attorney, her healthcare proxy. So long conversations with that. And her sister and the rest of her family prioritized the patient's health, knowing that it would save her life to end the pregnancy, which is devastating. This was a really desired pregnancy. She had just had a baby shower. This is an outcome that no one, wants to be in, but the safest thing, the way to save her life was to do an abortion. And she's since healthy and has gotten pregnant again and delivered a healthy baby. Wow. And none of that would have been possible. Right. Which also just goes to the strength and resilience of the human body. Yeah.
No, great. I understand now why it's called complex family planning. My house family planning is, what are we having for dinner or where are we going this weekend? But you've explained well how complex it is and how many different parties are involved with these types of decisions. But let's go back to pre-pregnant.
Okay.
Contraception.
Yes.
Media and politicians, they can make this topic controversial. Religion can get involved. We're not going to do that here today. We're going to keep this medical. Contraception is an essential part of women's health, women's rights, reproductive health. So talk to us a little bit about the common forms of contraception and the failure rate, what works, what doesn't work, starting from highest failure to maybe most successful contraception use.
That's exactly how I talk about it with patients.
I love it.
Yes, so contraception is essential healthcare for women and for men, right? Because that's how if on average, if a woman was in a heterosexual relationship and wanted to have 2 children, she would spend 30 years of her life trying not to get pregnant. That's like longer than most of us are in school. It is a whole job. And people have different needs at different times, but one of the most important things to people who want to use contraception is how well it works. So when we talk about contraception, there's 4 levels of effectiveness. The bottom level is like prayer, hope, and denial. If you're just hoping that you don't get pregnant and you're regularly heterosexually active, your chance of getting pregnant over the course of a year, 80%.
All right.
For the teens out there that may be listening. And then the second tier, condoms, anything you could find in the family planning aisle at the drugstore. So male and female condoms, diaphragms, spermicides, sponges, the pull-out method, those on average over the course of a year have a 20% failure rate.
That's higher than I thought. Most people think condoms work like 90% of the time or 99%.
The big difference is between perfect use and regular use.
I got you.
So perfect use is like you stocked up on condoms at the beginning of the month. They're right next to your bedside table. You remember where they are. You talk to your partner. Everyone's good with that. You put it on before there's any contact. You take it off soon after. I can't tell you the number of calls I've had from girlfriends over the years that like, we lost the condom, and then then the horse is out of the barn, right? Like the sperm that were in there are no longer contained in that little magic hat. So
20% failure with condoms, assuming no one uses it perfectly.
And then the next level up is the pill that you take every day, the patch you put on your skin that you change once a week, the ring that goes in the vagina that you change once a month, and then the Depo-Provera shot that you get every 3 months. And those on average have about a 10% failure rate. And again, it's just because if you're going to take a pill, someone's going to college and is going to be on the pill, they'll have to take 365 days a year times 4. That's 1,200 pills. You have to keep your prescription up to date. Your insurance has to be active. Your pharmacy has to stock it. You have to go and get it at the pharmacy. It's not that women fail the pill. I think the pill fails women.
Sure.
It's not a system that matches up with, I don't want to get pregnant for 5 years while I'm, in undergrad.
Not to mention some of the hormonal side effects that come with all of those medications.
Yeah, and some of the hormonal side effects are great, like periods that are lighter, shorter, with less cramping, but people also feel bloating and breast tenderness and emotional side effects. Not everyone, but if that's you, it's 100%. So the next level up, what I like to think of as the champagne of birth control, because I like champagne,
okay.
Although you might call it the scotch of birth control.
There you go.
Are the things that have less than a 1% chance of failing. And these are the methods that you set and forget. And so that's the IUD, the intrauterine device, which is a little T-shaped device that goes in the uterus and can last for anywhere. I mean, it could last for 1 month if you don't like it, but the longest lasting one can last for up to 12 years. There's a copper one that doesn't have any hormones in it for people who are really hormone sensitive. The downside with that, the copper one, because there's a downside with everything, including getting pregnant when you don't want to be. The downside with the copper IUD is it can make periods longer, heavier, and crampier. And that's not a big deal for some people whose periods aren't bad. But someone who's already bleeding for like 8 days, missing school or work because their cramps are so bad, the copper IUD is not a great option. But the hormonal IUD, which has a low dose of the female hormone progestin in it, which makes our periods lighter, shorter, with less cramping, can be really, really beneficial for them and desirable.
Is there anything above the champagne of contraception?
So it's the IUDs, the arm implant, which is just as good, and permanent contraception. So female sterilization and vasectomy. So all of those can fail, but they fail less than 1% of the time.
So let's say we're playing Powerball. We're not going to win. 1 in a couple million chances. All of these contraception options have failed. And now your patient has entered a situation where they are no longer unpregnant. They are pregnant, and maybe they don't want the pregnancy. It's unintended. What's that discussion like with you? When do you intervene and say, here's the options. Here's the whole host of things that can be done now?
This conversation is called pregnancy options counseling in obstetrics and gynecology. And it generally starts with, we're going to do a pregnancy test. What do you think it's going to show? Just to kind of gauge where someone's at, because we like to meet people where they're at in healthcare. And some people kind of are afraid, and that's why they came to the doctors. Other people are like, there's no way. And so they're really surprised. But the first part of that conversation then is to say your pregnancy test is positive. How do you feel about that? And people are like, that's the worst thing. crying, stress. Other people are kind of in equipoise, like, oh, I didn't want it to happen, but I didn't not want it to happen. And other people are like, it's a miracle, or, I didn't think I could get pregnant, or this is amazing. But I think we're talking about the first scenario where someone was using contraception, the contraception failed, they don't want to be pregnant. And if they confirm that, then we talk about what their options are.
So let's talk about some of those. And this is the unintended pregnancy group. Last week we talked a lot about fetal abnormalities and when abortion is maybe necessary and the best option, but we're not going to talk about that today. We're talking about unintended, unwanted pregnancies with someone who was using contraception poorly, and now here we are. So what are some of those options for abortion?
Yeah, and I just thank you for saying unintended and unwanted, because unintended probably is not the right terminology, even though that's what we use in public health. It's really the unwanted, because we all have friends that were like the caboose in the family and like, no, I wasn't intending to get pregnant with you, but like I did and it was okay. But it's really those with unwanted or undesired pregnancies. Up to 11 weeks, people have the option of either medication abortion or a procedural abortion. And then after that time, it's usually procedural abortions up until probably 18 to 20 weeks when a labor induction abortion is also an option. So medication abortion all abortion is safe and effective and it's safer than giving birth. The chances of dying while giving birth are about 14 times higher than the chance of dying from abortion.
I think what you said is very, very important and compelling information. I think it's underappreciated how risky of a procedure delivering a baby is.
Yeah.
And we don't really talk about maternal fatality or mortality.
Yeah.
So say what you said again about the risk of abortion versus the risk of delivering a baby.
Yes. Thank you. The risk of dying from pregnancy is 14 times higher than the risk of dying from an abortion. Because like you said, pregnancy is a risky time. Most of the time, women do well, but half of our blood volume is going to the uterus. And so anything that's happening in the uterus is severely compromising like the cardiopulmonary system of the pregnant person. And there's all kinds of things that can go wrong in pregnancy. They usually don't, but we have one of the worst maternal morbidity and mortality rates in the world compared to other countries similar to the United States. And those really break down around socioeconomic and racial barriers, that Black women are 3 times more likely to die in childbirth than white women.
And assuming these are relatively normal pregnancies and relatively healthy women?
Yes.
But just because of access and maybe ability to see healthcare providers, their risk
and a little
increases.
bit of racism baked into the system.
There you
probably.
go. We're going to talk about equity and diversity in a moment here. But talking about those two different abortion options, the medical and the surgical, talk to us a little bit about those.
So medication abortion starts with taking a medicine called mifepristone, which is an anti-progestin. And what it does is cause the pregnancy attachment to the wall of the uterus to weaken. And then the second pill is misoprostol, which is a prostaglandin and causes the uterus to contract and push out the pregnancy. And both of those pills work synergistically together in order to be greater than 95% effective at ending a pregnancy.
So if you're pre-11 weeks, you come to the doctor's office and take these pills and wait there until it all happens?
No.
Okay.
Great question. In general, there's a lot happening around who and how and when can give mifepristone, the first medicine, and some of the regulations which were overly constricting were lifted during COVID and are currently lifted, which is that it used to be that you had to take mifepristone in the doctor's office, that I had to physically give you the pill, I had to watch you swallow it, and then you went to the pharmacy to pick up misoprostol. Now you can come to the office and pick up the pill even if I'm not there, if I've already had the conversation and we've done consent and done it all via telehealth. Or you can also, in some states, mail the pill. This is all under a lot of scrutiny right now, given the Dobbs decision, which removed the federal protection for abortion, because there are many states that want to regulate medication abortion because it is something that can be done at home and done via telehealth and done via the mail. And that is not what those states want for their citizens.
So what happens after someone takes both of these pills? And is there a gap between when you take the first one and the second one?
There's actually a lot of flexibility, which is sometimes confusing, but the misoprostol can either be taken buccally, which means you put it in your cheeks almost like you're sucking on a hard candy, or it can be used vaginally. Depending on which route, either buccal or vaginal, you could do it at different times. And so it has to, the second medicine, the misoprostol, has to be taken within 72 hours of the first medicine, but you could tailor it to your life. So for some people, they may take the mifepristone on Friday and then say, you know what, what, we have a birthday party on Saturday. I'm not going to take the misoprostol till Saturday night because the mifepristone doesn't really do anything. It's not until 4 to 6 hours after you take the misoprostol that you start to have bleeding and cramping. And then that can last anywhere from like 6 hours to more like 24 hours. And it kind of has like a crescendo, decrescendo with trailing off of bleeding and spotting.
So then what happens? At home, women are in the bathroom or in bed or watching TV on the couch.
Yep.
What actually happens?
Bleeding and cramping. Most people don't see anything. It looks, because it comes out sometimes with clots, which is a normal, good functioning part of our body to clot blood. And some people are very interested in the process and will look to see what they can see. But what we tell people is to look for this heightening of symptoms where the bleeding and the cramping is really kind of at its worst. You're using ibuprofen, heating pad, you're like petting your dog like crazy, and then all of a sudden it gets better. Because at its most painful is when the pregnancy is actually passing through the cervix, like the doorway into and out of the uterus.
Any long-term complications with using these pills? Can women who use this pill then later on have a normal pregnancy?
Yeah, absolutely. No impact on fertility. The one thing that does have to happen after medication abortion is some kind of confirmation that it worked, because in about 5% of cases, it won't work just because of bad luck. And we want to find those 5% of people so that they don't think they're no longer pregnant, because then what happens is if they didn't get that verified, it didn't work, they're in that 5%, they could go for another 8 or 9 weeks till they feel fetal movement to know that they're still pregnant.
What does that confirmation look like? What actually has to happen?
There's a few different options. They can either come in and get an ultrasound to show that the uterus is empty. They can do the symptoms kind of that we talked about, the heightening and then decreasing of the pain and cramping and bleeding, and then do a pregnancy test a month out, because that's how long it takes the hormones to wash out of your system. Or they could do a blood draw that measures the pregnancy hormone on the day that they start the medication abortion, and then 1 week later.
So a lot of this still comes back to access and socioeconomics. Who has the ability to go get an ultrasound whenever they want, or get a blood drawn, or maybe even have access to a pregnancy test. So in that group of patients, it might be challenging to confirm that the pregnancy has been terminated.
Yes. So for people who probably the easiest, and I totally appreciate that it takes time, energy, and resource to come back to the doctor's office, to pay for parking, to like get childcare, to get time off of work. So to do the symptom check-in, and then we'll give them a pregnancy test in order to take that.
So tell us about the second option that you mentioned, which is the surgical abortion. What does that entail?
Surgical abortion entails cleaning out the uterus using a small handheld suction machine. Also very safe, very effective. We know right then and there whether or not it worked. It's about a 5 to 10 minute procedure. Some people choose that because it's not as long and drawn out as with the medication abortion, and they like knowing definitively that it's over. And then for people who choose medication abortion, they like being at home with their loved ones. They feel like maybe it's more private. And first trimester and even second trimester procedural abortion can be done in an outpatient setting, in our offices, at Planned Parenthood, or in the operating room for someone who desires general anesthesia. And
assuming with the procedural abortion, that confirmation happens at the same time. So there's no, quote, failure of a procedural abortion.
I mean, there can be, because the uterus can be tricky. But we know right then and there that it didn't work. Sometimes pregnancies are so small, and in women who have multiple fibroids, you cannot reach the pregnancy. If the pregnancy is implanted at the top of the uterus and then there's all these kind of boulders in the way, then medication abortion might actually be a better option because we can't reach it surgically. Or we wait until the pregnancy gets a little bit bigger if it's someone who's, say, 5 weeks pregnant, because then we could reach it.
Here at Weill Cornell, we have an Office of Diversity and Inclusion. We've touched on health equity a few times during this episode already. And you said this quote at your prior job over in Connecticut. You said, "Women with less financial resources and unstable housing, lack of transportation, living in rural communities, or in poverty will be the ones most affected by restricting access to abortion." Tell us about that.
Yeah, we know that there is not equal access to healthcare. We have 2, if not 3 different kind of tiers of healthcare. Those of us with private or commercial insurance, public insurance like Medicaid and Medicare, and then those that are uninsured. And so definitely having access to insurance is one of the biggest gatekeepers to being able to access care. And we know in states where abortion is most likely to be criminalized are also the states that have the worst child poverty, the worst maternal poverty, the worst maternal outcomes. Those are states that did not choose to expand Medicaid when it was offered under the Affordable Care Act so that more people could be covered. And there's a lot of working poor who fall between, working part-time at a business like Walmart where they don't get health benefits, but they make too much money to qualify for Medicaid. And they're really kind of stuck in the middle for having to pay out of pocket for things that are healthcare related. And we know that, again, in those rural states, women are looking at driving up to like 2 days in order to drive to a state where abortion is protected in order to access the healthcare that they need. And Black and brown women, those living in poverty, those who are disabled, those with less education, they're always the people who carry the burden of whatever restrictions are placed on healthcare.
One of the groups that we don't talk a lot about is peoples with disabilities. We talk about socioeconomic status, but what about the people who have a challenge just getting to the clinic, that they need somewhere and some method of providing care even in their home setting?
Yeah, absolutely. I mean, I think that's one of the promises of medication abortion. And what we saw during the pandemic, when offices were closed, when hospitals were restricted about who we could take care of because we had so many COVID patients to take care of, for the first time since medication abortion was available in early 2000, the number of abortions done via medication abortion rose over 50%, because when access was restricted, more people chose medication abortion. While it may not have been people's first choice because maybe they've never had it before or it just sounded horrible, we also know that like 80-90% of people who do medication abortion said they'd do it again. They were highly satisfied. They'd recommend it to someone else. So I think medication abortion is really a step forward in terms of being able to do a history over the phone, over telehealth, over video, or over the phone, and being able to prescribe those medications for someone and to do follow-up. People are smart and thoughtful. If you give them the right things to look out for and the contraindications, which are very few for medication abortion, like porphyria and high-dose steroids, people will follow that, will reach out to their doctors if there's a problem, and are very good at following directions.
That sounds like with the pandemic and opening this opportunity for a home medication abortion, that probably decreased healthcare utilization and time with OBs doing other things that they probably needed to be hands-on for.
Yeah, absolutely. And I think it showed just how safe and effective it is and how feasible and how acceptable it is for patients. And I think that unexpected silver lining of COVID, I think, is a path forward for us and for continuing to take care of women who are in these restricted states.
I totally agree. I think, when COVID and the pandemic first hit us in 2020, we didn't know where to go. And now with implementation of telehealth and remote patient monitoring, I think the quality of care might even get better because now they have access to healthcare professionals that normally require travel and money and parking, like you mentioned. When thinking about restricting access to terminating a pregnancy, one potential consequence that I'm thinking about in my head is that people might try to end their pregnancies without clinical supervision. Do you see that happening? And where does your mind kind of go when you think that that's a possibility?
Yeah, we know that happens. I mean, it happened before Roe was decided. It happens in countries where abortion is illegal. The same number of abortions are done whether it's legal or illegal. The only difference is how safe it is. Self-managed abortion is what that's called, and people have been doing it for centuries, because if you live in rural Texas and you don't have health insurance, you're just as likely to walk across the border and go to Mexico and get misoprostol only and do a self-managed medication abortion. It's not necessarily dangerous. It's not as effective as the mifepristone and misoprostol combined, but if that's what you have access to, and there are many websites, because technology can really help bridge these gaps sometimes, there are many websites that talk about what the dose should be, what to monitor, what are normal symptoms, and what are not. I think more so than initiating a self-managed abortion, I'm more concerned about the states that are criminalizing pregnancy altogether. And so what if they do have a complication, if they do hemorrhage at home, we think from prior research that they're going to be less likely to go to the emergency room, that they're less likely to call their doctor because they're afraid of going to jail. So I think more so than the self-managed abortion, the problem is the criminalization of pregnancy. And we've seen women go to jail for miscarriages that were deemed to be induced abortions, which weren't, but were caught up in litigation and awfulness for years before they could be freed from that.
Just speaking with you, it seems like the topic and the controversies around abortion and miscarriage and pregnancy in general is kind of enveloped in policy, which is not the purpose of healthcare. We're here to talk about women's health, not policy. No, I'm not disagreeing with your conversation. I'm saying that the topic is very confusing. In the United States, abortion is very politicized, and we talk about it in broad ethical terms, whether it's life versus death or privacy versus government intrusion. You know, in New York City, we're lucky right now. A lot of women's rights are protected. I want to say right now because who knows, things in the future can always change. But even though abortion is such a divisive topic in the United States, is the medical community unified on this? Do you converse with colleagues in some of these restricted states and get their opinion? What are they saying?
Yeah, absolutely. The medical community overall is uniform in its support for access to abortion, that abortion is essential health care. That statement and that sentiment has been supported by and promoted by the American College of OBGYNs, by the American Medical Association, by the Society of Family Planning, by the other subspecialties of OBGYN. There is universal broad support for abortion as essential health care. There are always individuals who disagree. There are anti-abortion OBGYNs or anti-choice, and they have their own kind of viewpoints, but they are really in the very, very, very small minority. And also, public polling shows that most Americans are in support of abortion and are unhappy with the overturning of Roe. When you get into the semantics of how many weeks or this, then people, the numbers start to kind of go down in terms of support. But overall, it's like 2/3 of Americans that support access to abortion. And I do have friends in red states, friends who on Friday, when Dobbs was decided, had to call their Saturday patient, someone, a colleague in the Midwest who was taking care of a patient whose pregnancy was affected by anencephaly, so no brain, not a pregnancy that would result in any kind of quality of life. And sure, some women who have that kind of pregnancy may choose to continue to stay pregnant and to deliver that baby, to see it and say goodbye and provide hospice care. But that's not everyone. Other people want to end the suffering and move on and not, have people continue on the street, ask them about their pregnant belly or have their kids ask about that.
And not to mention that it's riskier to carry this to term anyway.
Absolutely.
Very challenging stuff. What are some misconceptions out there? You have the ears of a few thousand listeners, hopefully 20,000. And what do people not know about abortion or terminating an unwanted, unintended pregnancy?
Yeah, we talked about how safe it is. I think that's really a myth because non-scientists or non-physicians, non-public health people want to say that abortion is harmful, that it's unsafe, which is not true. They also want to say that it harms women's mental health. There's actually a fantastic study that your listeners may or may not be interested in called the Turnaway Study, and it followed a couple thousand women who presented to an abortion clinic wanting to end their pregnancy and were really close to the gestational age limit. And so some of those were able to get their abortion and some weren't. And then those women were followed for several years. And the women who got their abortions had no more depression or anxiety or anything than the women who didn't get their abortion. So there was no difference in maternal and mental health. The mental health outcomes were really tied to any pre-existing condition. So people who have pre-existing depression may likely battle that for years. What it did show is that the women who were denied an abortion and forced to continue, very few chose adoption, which is what some people like to think, that all of these women who are forced to continue their pregnancies, like, oh, just give the baby up for adoption. That we could do another podcast on that. But that those women who were forced to continue the pregnancy were more likely to stay with a violent partner, were more likely to be in bankruptcy and have their credit scores ruined, had worse developmental outcomes for the children that they were already caring for, because in general, 60% of people who are getting an abortion are already mothers. And so really, we know that forced birth has negative outcomes for both the mother and the children that are already there. And we're waiting to hear the outcomes of the other pregnancies.
Yeah. We're not here to talk about when life begins. That's a whole nother episode also. But just speaking of the impact on the woman and her rights and her reproductive health in terms of carrying a pregnancy to term is complicated. And, I think you're doing the right thing. You're advocating for your patients, for women to decide what they want to do when they want to do it, for their families and what's best for them. So I applaud you for your efforts there.
Thank you. I appreciate that.
Dr. Gariepy, welcome to Weill Cornell.
Thank you.
I'm glad you're here with us. So we're going to collaborate on patients like we talked about before. And, I have patients who come to me all the time who are in the pre-pregnancy planning phase. And I refer all my patients to your group. Like I mentioned last week, we had both of our kids here with your department. So we're very, very happy for what you guys have done for us. But thank you for sharing with us your insight on contraception, on the various methods for abortion. And just like you stated, family planning is complex, and there's a lot of moving parts and a lot of specialists and people involved in that decision. So it's great that you are coordinating all of that with your clients, your patients. And thank you out there to the listeners of The Backstory. I hope you enjoyed today, part 2 of our look on abortion and women's health and reproductive rights. Thank you for tuning in. And remember, when it comes to your health and wellness, we've got your back. Thank you.
Thanks for listening to The Backstory. Please subscribe, rate the podcast, and review The Backstory on Apple Podcast, Spotify, and Google Play Music. And feel free to share this podcast on social media or even your own website or blog. This podcast is for general information purposes only. It does not constitute the practice of medicine, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information is at the user's own risk. The content of this podcast is not intended to be a substitute for medical advice. To learn more about Dr. Singh and his clinical research, please follow him on social media. You can also sign up for his newsletter by going to www.rickysinghmd.com. That's RICKYSINGHMD.com.